Thanks, Kelly. It is truly an honor to be with you here today. In the United States, Human Rights Watch has documented the widespread inappropriate use of antipsychotic drugs in nursing facilities, often without informed consent. According to U.S. Government Accountability Office analysis, facilities often use the drugs to control common symptoms of dementia. Both inappropriate use and a lack of informed consent arise primarily from inadequate enforcement of existing laws and regulations. Our report, They Want Docile, How Nursing Homes in the U.S. Over-Medicate People with Dementia, was released in February. I can see that many of you have picked it up at the front of the room. Today, I'm going to set out who we are as Human Rights Watch, what our research was and what we found, and our recommendations. But first, a little framing. Older people now account for 1 in 7 Americans, almost 50 million people, and that will double in the coming decades. Put another way, about half of all the babies born last year in the U.S. will live to celebrate their 100th birthday. The number of Americans with Alzheimer's disease, the most common form of dementia, is expected to increase from 5 million today to 15 million in the coming decades. And our system of long-term care services and supports will have to meet the needs and respect the rights of this growing population in the coming years. Human rights are what govern the relationship between governments and people. We at Human Rights Watch lay responsibility squarely at the feet of the government for protecting us from the practices that we're talking about today. Human Rights Watch is an international organization working in 90 countries around the world, and some here may be familiar with our work in other parts of the world and may be surprised to learn that our largest body of work by far is our work here in the U.S. We investigate human rights violations, expose them to the world, and seek to use this leverage to create accountability for change. Human Rights Watch has a long history of working for the rights of people living in institutions like prisons, psychiatric institutions, and orphanages. We have this focus because of the inherent heightened risks to violations of rights that are created when there's a forced dependence on an institution, when people are living cut off from the rest of society. Human Rights Watch is the first mainstream human rights organization to dedicate work specifically to the rights of older people. As Human Rights Watch's researcher on older people's rights, I chose this issue because of the relentless work of many of you in the room. Together, you shine a spotlight on the way we treat each other in older age. Many of you have worked, in some case for decades, against a practice that is quietly killing people and robbing them of conscious life, hidden away from the rest of society. Antipsychotic drugs' sedative effect, as we all know, rather than any anticipated medical benefit, too often drives the high prevalence of use in people with dementia in nursing facilities. They alter consciousness. They adversely affect an individual's ability to interact with others. They can also make it easier for understaffed facilities with direct care workers who are inadequately trained in dementia care to manage people who live there. In many facilities, inadequate staff numbers and inadequate training make it nearly impossible to take an individualized, comprehensive approach to care. Many nursing facilities have staffing levels well below what experts consider the minimum needed to provide appropriate care. And this is really important when we're talking about dementia care and we're talking about prevention of the use of antipsychotic drugs, what the alternatives are. Regulations require that a person's behaviors be first managed through checking to see if someone is in pain, through checking to see if someone has an illness, through redirection and behavioral interventions, non-pharmacological interventions. But those things require people. Nursing facility staff, individuals living in facilities, their families, long-term care advocates, and others told Human Rights Watch that the drugs are not used only as a last resort after those other things have been tried, but they've often been used as a matter of course. I want those of you who are not so familiar with the topic to come away knowing a few things. Lisa Marsh Ryerson said it well when she said that this is illegal and immoral, and it's a big problem. This is happening to 16% of nursing home residents in the U.S. That's 1 in 6. And I want you to come away knowing that there are many different solutions for this problem. We had a brilliant year-long fellow with us last year who conducted the bulk of this research. Many of you know her here. I conducted some of it together with some other researchers. Together, we covered over 109 facilities and did over 300 interviews in 6 states around the U.S. We focused on facilities that have over 50% of their residents over the age of 65, and we focused on facilities that have reported having high rates of antipsychotic use. We analyzed publicly available data on the use of drugs, pulling together data from multiple data sets. There was no way to find this on its own. And we made this clickable map, which I hope that you'll all have a look at after this presentation, that shows county by county how many older people are in nursing facilities in those counties, what the rate of antipsychotic drug use is there, and what the number of staffing hours are on average for those facilities. We did take the time to analyze data excluding diagnoses such as schizophrenia, Huntington's, or Tourette's, to make sure that we were just looking at cases where people who have a diagnosis of dementia only were on these drugs. Many of you here already call this practice for what it is: chemical restraint, unnecessary drugs, medical coercion. In 2013, Juan Mendez, who is the UN expert on torture, noted that, and I'll quote, "medical treatments of an intrusive and irreversible nature, when lacking a therapeutic purpose, may constitute torture or ill treatment when enforced or administered without the free and informed consent of the person concerned. These treatments may constitute ill treatment, notwithstanding claims of good intentions or medical necessity." These antipsychotic drugs in the context of nursing facilities are often given without free informed consent, which requires a decision based on a discussion of the purpose, risks, benefits, and alternatives to a medical intervention, as well as the absence of pressure or coercion in making the decision. These drugs are dangerous. In clinical trials, they almost doubled the risk of death for older people with dementia over a 10-week period. Without informed consent, people are not making the choice to take on that risk. In line with international human rights law, U.S. law and regulation prohibit the use of antipsychotic medicines as chemical restraints for the convenience of a facility. Nursing facilities are required to have an adequate medical basis for initiating the use of an antipsychotic medication. The practicalities of obtaining consent from an older person with dementia can be fraught. However, in many of the cases Human Rights Watch documented, nursing facilities made no effort to obtain meaningful informed consent from the individual or health proxy before administering medications, in many cases where it clearly would have been possible to do so. Our research suggests that in many other cases, facilities that purport to seek consent fail to provide sufficient information for consent to be informed. They pressure individuals to give consent or fail to have a free and informed consent procedure and documentation system in place. Under international human rights law, the absence of free and informed consent when there's a non-emergency medical intervention is called forced treatment. And what does that look like in real life? We talked with people like Ruth, who at 62 had a minor stroke and went to a nursing facility for rehabilitation. After a month there, the staff had not had a care plan discussion with her. Instead, she told us the facility administered an antipsychotic medication without informing her or seeking her consent. The medication, Seroquel, she told us, made her see monkeys on the wall. She slept all the time. She felt like she was going to die. So she started refusing to take it. She told us that after that, she found the drugs in her food, in her applesauce. Twice during our interview with her in that facility, nursing staff came into the room with a gel, so a transdermal form of Seroquel, and attempted to administer it to her, twice in the span of a 40-minute conversation. She told us that she feared the facility's retaliation for her refusing to take the medications and for talking with us and an ombudsman. The state ombudsman worked with her to get her released from that facility the following day. Ruth's story is not unique. We talked with a daughter in California whose mother experienced a painful pulmonary embolism while on an antipsychotic drug in a nursing facility there. The facility had administered the drug to keep her quiet. Her daughter told us that if she were in pain and unable to use words the way her mother was unable to use words, that she would scream too, and I think we all would. Our research found significant shortcomings in enforcement of federal regulations to protect nursing home residents from the underestimation of harm cited to the inadequate deterrent effect of fines around these drugs' use. CMS guidance for surveyors suggests that in many cases of inappropriate use of antipsychotic medications, that harm should be cited at a level 3 or 4. Yet, Human Rights Watch data analysis suggests that deficiencies related to antipsychotic drugs, so when the survey is being done in a nursing facility, those drugs' use is almost uniformly cited as level 2 or below. We reviewed more than 7,000 deficiency reports related to antipsychotic drugs between January 2014 and January 2017, and found that 97% of these deficiencies were tagged at level 2 or below. Our quantitative analysis of the fines that were associated with those top-level citations found that 80% were less than $10,000, and 20% were between $10,000 and $100,000. These minimal monetary fines may not be significant enough to deter malfeasance. Some might suggest that voluntary measures and a good complaints procedures, like a well-funded ombudsman program, could be an alternative solution to regulatory enforcement. But many individuals in nursing facilities are physically frail, have cognitive disabilities, and are isolated from their communities. Often they're unable or not permitted to leave the facility alone. Many depend entirely on the institution's good faith and have no realistic avenues for help or for safety when that good faith is violated. Many don't have family or friends to support them. Think about that. If I've been put on these drugs and I don't have anyone visiting me to notice that I am asleep all the time, it's like a tree falling in the forest with no one there to hear the sound. If I'm too drugged up to open my eyes, to walk, or to eat, I am not going to be able to seek help. Strict enforcement of regulations is the absolute minimum that government, CMS, needs to do to protect people. Our research found that CMS is not using its full authority to address this issue. Recently, CMS is in fact moving in the opposite direction, limiting the severity of financial penalties. In 2012, CMS created the Voluntary National Partnership to Improve Dementia Care in Nursing Homes. This sort of initiative, while admirable, is no substitute for the effective regulation of nursing homes, including by ensuring that facilities face meaningful sanctions for noncompliance with mandatory standards. To recap, Human Rights Watch identified several key areas of concern. First, failure to adequately enforce the right to be fully informed and to refuse treatment or to require free and informed consent. The Nursing Home Reform Act of 1987 grants residents the right to be fully informed in advance about care and treatment, to participate in care planning, and to refuse treatment without penalty. If it were enforced fully, these protections would not differ substantially from the right to free and informed consent. However, without adequate enforcement, current practice falls far short of this protection. Second, a lack of minimum staffing regulations. Adequate numbers of sufficiently competent staff are at the crux of nursing facility care, yet government regulations do not set a minimum staffing requirement for nursing facilities, instead requiring that facilities determine for themselves what amounts to sufficient and competent staff. While experts put minimum adequate staffing time at 4.1 to 4.8 hours per resident per day on average, most facilities self-reported to the government providing less than that. Almost 1,000 facilities self-reported providing less than 3 hours of total staff time per day per resident. Our third and final concern is the weak enforcement of federal regulations specifically banning chemical restraints and unnecessary drugs. Federal regulations prohibit chemical restraints, drugs used for the convenience of staff or the discipline of residents without a medical purpose, and unnecessary drugs, which is a technical term meaning drugs used without adequate clinical indication, monitoring, or tapering. The regulations also provide for the right to refuse treatment. However, the federal and state enforcement of these regulations is so weak that the drugs are routinely misused without significant penalty. Almost all antipsychotic drug-related deficiency citations have been determined to be at a level of causing quote-unquote no harm, that 2 or below, curtailing the applicability and severity of financial sanctions. In closing, our report found that vast numbers of nursing facility residents are getting antipsychotic drugs that many do not need, do not want, and that put their lives and quality of life at risk. An industry entrusted to provide care and paid billions of public and private dollars to do so cannot justify compounding the vulnerabilities, the challenges, the loss that people often experience with dementia and institutionalization. Our message is that federal and state governments need to do more to ensure that the rights of residents are adequately protected. We are proud to stand with many of you here today as you're working to fight this injustice. And thank you very much for listening.